Hello and a warm welcome to everyone. Welcome back to my channel. I'm Dr. Mithila and today we are going to delve deep into another important topic of liver pathology, that is metabolic dysfunction associated steatotic liver disease, that is MASLD. Now we are more familiar with its earlier terminology, that is non-alcoholic fatty liver disease, but now this term has been changed to MASLD. And we'll also study about metabolic dysfunction associated steatohepatitis, MASH. Again, the earlier terminology for this is non-alcoholic steatohepatitis. So these terms have been changed and we should know about these terms. And MASLD is the most common cause of chronic liver disease in the US. So it has got clinical significance and it is often considered as a silent killer because many people are unaware of the disease process going inside their body, and it is most often detected incidentally. Now, before we move on to this topic, I would recommend you to go through the previous lecture that I've uploaded on the pathology of alcoholic liver disease for a better understanding. So, where did this new nomenclature come from? So, it was brought up by a panel of experts consisting of more than 200 experts in this field, and they belong to more than 50 countries, and they carried out various surveys and a number of meetings, after which this new nomenclature was given. So the words such as fatty and non-alcoholic, they were considered as stigmatizing, and they were not able to provide the clarity on the causes of fatty liver. So there was a need to make these names more clear, and because of this, this nomenclature was introduced, and now it is widely accepted all over the world, and it has even been included in our Bible of Pathology, that is Robbins. So it mentions these new terms in the chapter of liver pathology. Now I will briefly tell you regarding the updates in the new nomenclature that is used. Now let us have a look at this. So there is one broad term which is steatotic liver disease. Earlier it was known as fatty liver, which is now discontinued. So, steatotic liver disease is often detected incidentally on your routine radiology, and the SLD can have a number of causes. So, one cause is metabolic dysfunction associated steatotic liver disease, and there is a progressive form of MASLD, that is metabolic dysfunction associated steatohepatitis. Then there can be specific etiologies, for example, drugs which can cause steatosis in the liver. Then there is another category that we studied in the last lecture, that is alcohol related liver disease. So again, that can cause steatosis in the liver. This is a new category, new term that has been introduced. It is metabolic and alcohol related liver disease. So in this category, the patients, they have some cardiometabolic risk factor. Along with that, there is a defined uptake of alcohol by the patient. And if no other cause is known, then it is known as cryptogenic steatotic liver disease. So these are the different categories that come under this umbrella term, which is steatotic liver disease. So this has made the different etiologies more clear and comprehensive. So now we can categorize them more accurately, and then we can have better treatment plans. Now this next image again explains the subcategorization of the steatotic liver disease. So the patients who have any one of the 5 cardiometabolic risk factors, they are classified as metabolic dysfunction associated steatotic liver disease, that is MASLD. Now MASLD in its progressive form, it is known as metabolic dysfunction associated steatohepatitis, or MASH. So MASLD can progress to MASH. Now we come to the next category, which is a new category. The category is known as MET-ALD. So these were the patients who have one of the 5 cardiometabolic risk factors. Along with that, they also consume some amount of alcohol, which is defined in this category. So the amount is 140 to 210 gram per week for the females, And for the males, it is 210 to 350 gram of alcohol per week. And these are the criteria for the daily intake of alcohol in grams. So 20 to 50 grams per day for a female and 30 to 60 grams per day for a male. So this is a new category that has been introduced in this classification, and it is for the patients who are consuming alcohol and also they have a cardiometabolic risk factor. Then we have the category alcoholic associated or alcoholic related liver disease that we covered in the last lecture. In alcohol associated liver disease, there is a very high intake of alcohol, and that is driving the damage taking place in the liver. Now the other categories, so there is specific etiology SLD. So it has got some specific etiologies like drug intake, certain drugs which can cause steatosis. And the last category is where the cause is unknown. So that category is known as cryptogenic steatotic liver disease. So there's a very nice diagram. It shows the full spectrum of steatotic liver disease. The most important is MASLD and MASH, in which there is at least one cardiometabolic risk factor. Then the patients who are having a cardiometabolic risk factor along with a moderate amount of alcohol intake, which is defined here. So that category is MAT-ALD. Then alcohol associated liver disease, ALD, where there is high intake of alcohol. Then specific etiologies leading to the steatotic liver disease. And lastly, when no cause is known, then it is known as cryptogenic steatotic liver disease. So these are all the causes where the steatosis can occur. And earlier it was known as fatty liver. Now it is called steatotic liver disease. Now next is the cardiometabolic criteria that is important to diagnose MASLD, because the patient should have hepatic steatosis along with that one of these 5 cardiometabolic risk factors. And these factors have also been defined in the pediatric age group, because we know that in the pediatric age group also these metabolic disorders, they have become very common. So in the adult criteria, the criterias are there for the BMI, waist circumference, fasting blood glucose, blood pressure, plasma triglyceride levels, and then HDL cholesterol levels. So you can just go through this list. Now with all this knowledge, we can easily understand this flowchart. So a patient who is having steatotic liver disease, that is the hepatic steatosis, is identified by imaging or biopsy. Then if the patient has the cardiometabolic criteria, then if there is no other cause of steatosis, the patient is known to have metabolic dysfunction associated steatotic liver disease. But if other cause of steatosis are seen, like alcohol intake, so then the patient will come in the category of MAT-ALD or ALD, depending on the amount of alcohol consumed per day or per week. Now, if there is no cardiometabolic criteria, then if there is any other cause like drugs, then the patient comes under the specific etiology SLD. And if no cause is known, then it is said to have cryptogenic SLD. Now that we have understood the new terminology and how to diagnose these conditions, I will tell you the outline of this lecture. So we will take up MASLD and MASH, covering the following headings. So without any further ado, let's proceed further. So what is MASLD? It is metabolic dysfunction associated steatotic liver disease, and there is presence of hepatic steatosis, fatty liver, in individuals who consume very little or no alcohol and who do not have any other cause of hepatic fat accumulation. And as we studied, there should be presence of one out of those 5 cardiometabolic risk factors. So then we will label the patient as having MASLD, and there should be no other cause of hepatic steatosis like hepatitis C virus or Wilson's disease or any medication. So then we will label the patient as MASLD. Now the MASLD has the histologic features similar to alcoholic liver disease, that is there will be steatosis, later on there will be steatohepatitis, and later on fibrosis, and in the end there can be cirrhosis. Now MASLD, as this new name suggests, it is associated with metabolic disorders like diabetes, mellitus type 2, obesity, hyperlipidemia, and it has a strong association with insulin resistance. Next is MASH MASH. So earlier it was called as NASH, and it is a more severe form of MASLD, which is showing steatohepatitis. So there is steatosis and there is lobular inflammation of the liver, and then there is risk of progression to fibrosis and subsequent cirrhosis. Ultimately, the problem is the risk of cirrhosis and the hepatocellular carcinoma if MASH is present. The histologic features of MASH, they are very much similar to alcoholic steatohepatitis. So there is basically inflammation plus injury to the hepatocyte. Now, this has a risk of progressing to fibrosis. Ultimately, liver cirrhosis and decompensated liver. Talking about the epidemiology, MASLD is the most common cause of chronic liver disease in the United States, and it is a disease of major public health concern. And the prevalence of an MASLD is projected to be about 30% by the year 2030. This alarming rise in MASLD, it is linked to the global rise in the metabolic disorders like obesity, type 2 diabetes, and other metabolic risk factors. Now, next we move on to the spectrum of lesions that can be seen in a patient with MASLD. So, there's a picture taken from the Robbins 11th edition. So, if there is MASLD, it can progress to metabolic dysfunction associated steatohepatitis, which is a more progressive form of MASLD if the precautions and treatment is not taken. This MASH is clinically significant because it can later on progress to fibrosis, and with fibrosis there is again a risk of development of cirrhosis, and liver decomposition can occur, and also it can lead to hepatocellular carcinoma. So that is why diagnosis of MASH is very important. But most commonly, in more than 80% cases, there is only isolated fatty liver or steatotic liver disease, and this condition is very much reversible, and there is minimal progression to cirrhosis, almost never progresses, and there is no increased risk of death as compared with the general population. So in majority of the patients it has a benign course. So the goal has to be to diagnose MASLD and MASH at an early stage, so that the progression to hepatocellular carcinoma or advanced cirrhosis can be prevented. Now in this slide, this is just a visual depiction of what I told in the last slide. So the normal liver, it starts accumulating fat when it develops MASLD. Mostly this condition is non-progressive, but it can progress to metabolic dysfunction associated steatohepatitis, and in the steatohepatitis, the liver will get damaged, the hepatocytes get damaged, and there is increased risk of fibrosis as well as cirrhosis. In steatohepatitis, the liver is fatty as well as inflamed. Later on, when the fibrosis develops in the liver and it progresses to the final stage of cirrhosis, the liver becomes scarred, the outer surface becomes irregular, and the liver architecture is destroyed. So here we get a scarred and bumpy liver. Now next we come to the important topic, that is how MASLD develops. That is the pathogenesis of MASLD and its progression to MASH. The main drivers of MASLD and later on MASH are the lifestyle factors, and mostly they are related to our diet and the sedentary lifestyle. So junk food, processed foods, high sugar diet, and high fatty diet, they all are the culprits for development of this MASLD. So now let's move on to the various etiologies that can cause the MASLD. So most importantly, metabolic syndrome, diagnosed by the following WHO criteria. So patient will have one of these diabetes or impaired glucose tolerance or impaired fasting glucose or insulin resistance, and two of these features, that is raised blood pressure, dyslipidemia, central obesity, microalbuminuria. So some of the factors, these are overlapping with the cardiometabolic risk factors that we discussed earlier in the diagnostic criteria of MASLD. So metabolic syndrome, obesity, diabetes, insulin resistance, dyslipidemia, hypertension, all these play a role in development of the metabolic dysfunction associated steatotic liver disease. And now the diagnostic criteria is quite clear that patient should have one of the 5 cardiometabolic risk factors, then he or she will be labeled as MASLD. Now let's move on to the pathogenesis. So if the patient is obese, he has got lot of visceral fat, there is presence of insulin resistance in the patient, and because of the insulin resistance, there is lot of dysfunctional adipose tissue, and that dysfunctional adipocytes, they got the decreased production of adiponectin, because of which there is decreased oxidation of fatty acids, and there is also increased activity of lipoprotein lipase. So because of this, there is increased release of fatty acids, and these fatty acids, they are taken up by the hepatocytes. Additionally, the hepatocytes, they also downregulate the lipolysis, because of which again the fatty acids increase. Now these fatty acids, they are stored as mainly as triglycerides in the liver cells. Now because of this accumulation of fat inside the liver, the most important problem that occurs is the lipid peroxidation and oxidative damage to the hepatocytes. So when this occurs, the steatotic liver disease often progresses to steatohepatitis, and later on there can be fibrosis and ultimately cirrhosis and lastly liver failure. One additional point is the dysfunctional adipocytes. They also cause the release of certain chemical mediators like TNF alpha. TNF alpha is an inflammatory mediator, so again it will cause inflammation and hepatocyte damage in the liver. So I hope this diagram is clear, and it explains how this insulin resistance and obesity, it is leading to liver damage. Not just the etiological factors, there are certain cofactors as well, and the role of these cofactors is to determine the acceleration of the disease process. So what are those growth factors? So in MASLD also there is increased gut permeability to the gut endotoxin. So these endotoxins, they get absorbed from the gut and they reach the liver. In the liver, they have got their receptors on the Kupffer cells. And when these endotoxins, they bind to the Kupffer cells, they release the inflammatory mediators. They will cause the damage to the hepatocytes. Then polymorphisms in these genes, they will also play a role in acceleration of the disease. Then high fructose diet accelerates the fibrosis. High fatty diet accelerates the hepatocyte injury in MASLD. Obstructive sleep apnea, which is associated with intermittent hypoxia, so that will also cause accelerated damage to the liver. Now, if the patient is also having additional diseases like hemochromatosis, then again the patient will have accelerated fibrosis. So all these factors, these are playing a role in progression of the disease at a faster pace. Now this diagram from the Robbins, it illustrates the pathogenesis of MASLD, and it has got all the components that I already described. So there are cofactors, environmental factors like gut microbiome, dietary fat, metabolic factors like obesity, insulin resistance, presence of these dysfunctional adipocytes, which are ultimately causing the increase in the free fatty acids. So these free fatty acids, they are uptaken by the hepatocytes, and in the hepatocytes there will be lipid peroxidation, because of which there is necrosis of the hepatocytes, damage to their plasma membranes, mitochondrial dysfunction. All this is leading to the hepatocyte injury, and there is also inflammatory response, as we discussed earlier, by the Kupffer cells and also by some inflammatory mediators released by the dysfunctional adipocytes. So that will cause the inflammation and fibrosis associated with the MASLD. And the free fatty acid accumulation, that is stored in the form of triglycerides in the hepatocytes, and it is causing steatosis. So mostly there is non-progression of steatosis, but when there is more hepatocyte injury, then it will progress to steatohepatitis. Now next we come to the morphology of MASLD. So it is very similar to the alcoholic liver disease. So just go through the last lecture of mine, you will get a better understanding. So first stage was hepatic steatosis. So in steatosis, we know that there is accumulation of the fats inside the hepatocytes. So grossly the liver becomes enlarged, pale, smooth, and the cut surface is yellowish and greasy. The weight of the liver is about 4 to 6 kilogram. So normal weight is 1.2 to 1.5 kilograms. So it increases in size. The changes of steatosis, they starts from the centrilobular region and later on they go to periportal. In the microscopy, the architecture of the liver will be preserved in steatosis. The steatosis, it is more as compared to the alcoholic liver disease. So in MASLD, the steatosis is more than in ALD. Then second differentiating point is the macrovesicular steatosis. It is more commonly seen in MASLD, while in ALD they will be microvesicular. So here in the image you can see the microvesicle. In this there is multiple vacuoles which are seen in the hepatocytes, while in the macrovesicular form there are a lot of fat in the hepatocytes and the nucleus is pushed to the periphery. So this is the macrovesicle. So this is more common in MASLD. We call it steatosis when more than 5% of the hepatocytes, they are showing this fatty change. The fats, they cannot be demonstrated by the routine stains. So they are demonstrated by special stains like oil red O, Sudan black B on frozen section. This is a microscopic image, HND stain, and we can see the macrovesicular steatosis. So this is the hepatocytes, it's having a clear cytoplasm because the fat is not stained in HND, and this is the nucleus pushed at the periphery. So all these are the macrovesicles and these are the microvesicles. Here the nucleus is central and the cytoplasm is showing these foamy appearance because of the presence of lipids. So the macrovesicular steatosis is more predominantly seen in the MASLD. There's a special stain which is the oil red O stain, so it can be used to demonstrate the fats. Now we come to MASH, that is metabolic dysfunction associated steatohepatitis. So this is similar to the alcoholic steatohepatitis in terms of the histologic features. So we will see ballooning of the hepatocytes. So the hepatocytes, they get swollen up and the cytoplasm becomes foamy. Then there is lobular inflammation, such as inflammation consisting of neutrophils, lymphocytes, and macrophages sometimes. Then we studied in the last class this Mallory Dank bodies. So these are ubiquinated cytokeratins. So cytokeratin 8 and 18 mainly. So they get attacked to the protein ubiquitin and it is seen as the ropey structures inside the hepatocytes. So they are known as Mallory Dank bodies and it is a sign of cytoskeletal disorganization occurring because of the hepatocyte injury. So these Mallory Dank bodies again is important from the exam point of view. From the NEET PG image based question can come. So on the arrowheads you can see these pink structures. These are the Mallory Dank bodies and these are ubiquinated cytokeratins, intermediate filaments. And in the background you can see these the hepatocytes which are showing the ballooning degeneration, the swollen hepatocytes. These Mallory Dank bodies, they can also be demonstrated by the immunohistochemistry using ubiquitin. So they are better demonstrated with this ISC stain. So all these are the Mallory Dank bodies. Now again MCQs, the Mallory Highland bodies, they can be seen in alcoholic liver disease, MASLD, then they can also be seen in Wilson's disease, early childhood cirrhosis, alpha-1 antitrypsin deficiency, primary biliary cirrhosis, and HCC. So you have to remember this from the MCQ point of view. The metabolic dysfunction associated steatohepatitis, the activity has to be scored for the prognosis of the patient. So the activity is scored based on the level of steatosis, the number of cells involved by this fatty change, then the lobular inflammation that is seen, and ballooning degeneration. Another important prognostic factor is fibrosis. So steatohepatitis can progress to fibrosis and there is accumulation of fibrosis and collagen in response to the inflammation and injury that is occurring to the hepatocytes. So here the special stain, Mason trichrome stain, is used. These are the liver cells showing the steatosis, and here this is the fibrosis. So all these blue lines and these hexagonal structures which are formed because the fibrosis is pericellular here, so it gives appearance of the chicken wire. So it is known as the chicken wire fibrosis. And you should also remember the conditions where chicken wire fibrosis is seen. We have discussed it in the last lecture. So the chicken wire fibrosis starts from the zone 3, that is central lobular zone, and later on moves to the periportal fibrosis and bridging fibrosis. Ultimately, it can lead to cirrhosis. So special stain that is used is Mason trichrome stain. So the fibrosis is scored because the extent of fibrosis is the most important and critical prognostic factor. Just few points to be summarized in microscopy, that in alcoholic liver disease, the steatosis is less as compared to the steatosis in MASLD. And also the macrovesicular steatosis is seen more in MASLD, while in ALD it is the microvesicular steatosis. Now in ALD, the lobular inflammation, balloon hepatocyte, neutrophilic infiltration, cholestasis and obliterated central veins, they are more in alcoholic liver disease. So alcoholic liver disease, it develops more severe disease. While in MASH, generally it has less hepatocellular damage and more of steatosis. Now MASLD is also becoming very common in the pediatric age group, considering the epidemic of pediatric obesity that is seen these days. So in pediatric MASLD, there will be more diffuse steatosis, while in adult it is less. Portal fibrosis will be seen more in pediatric MASLD, while we have studied that the fibrosis started centrally in adult MASLD. Now ballooning degeneration is seen in adult MASLD and it's not seen in pediatric. So you should know these differences. Now, if we talk about the clinical aspects, so majority patients, they have no symptoms, so it is also considered as a silent epidemic. And in the early stages, the patient has no symptoms, and mostly the patient has a incidental detection of this fatty liver on the ultrasound. Clinical picture is related to the metabolic disorders, so whatever cardiometabolic risk factor the patient has, so he will or she will present accordingly. Patient can have diabetes mellitus, can have obesity, maybe on antihypertensive treatment, or maybe on anti-hyperlipidemic drugs. However, in the late stages, some symptoms may be seen like fatigue, pain in the upper right abdomen, weight loss, jaundice, and in the end stages, when the patient develops fibrosis and ultimately cirrhosis, the patient can have portal hypertension and other signs of hepatic failure. So after the clinical picture, let's move on to the lab investigations. So lab investigations are very important. The blood test can be done, liver function tests, here the enzymes, ALT, AST, GGT, ALP, they will be raised. And in the advanced liver diseases, they can even be normal when the liver loses its functional capacity. And imaging can be done to demonstrate fatty liver. In this, we can do the ultrasound, CT, MRI. Now, this fibroscan is becoming very, very popular because it is a non-invasive method and it tells about the degree of fibrosis in the liver. So, it is done. However, liver biopsy remains the gold standard for a definitive diagnosis of MASH. To detect the underlying cause, the other investigations can be the level of blood glucose, then HbA1c. They can be done as a part of the metabolic profile. Similarly, the lipid profile, all these can be done as a part of lab investigations. So these are the key concepts I have taken from the Robbins. So MASLD is associated with the metabolic syndrome, obesity, type 2 diabetes mellitus, hyperlipidemia. So the patient should have one of the 5 cardiometabolic risk factors to have a diagnosis of MASLD. And MASLD which will show the histologic changes which are similar to those of alcoholic liver disease. So there will be steatosis, steatohepatitis, and fibrosis. Later on, cirrhosis in the end stage. Diagnosis requires biopsy. Some radiological investigation, blood test can also be done, but biopsy is the gold standard. it is very difficult to distinguish it from alcoholic liver disease without a clinical history. So the history of alcohol consumption and the quantity of alcohol consumed per day is very, very important. Now, pediatric MASLD is increasingly recognized as the obesity epidemic is seen in the pediatric age groups as well. So the histologic features, they need to be distinguished from the adult MASLD. So the ultimate goal in MASLD and MASH is to reverse the histologic features, to correct the underlying risk factors, and to reverse the fibrosis, and to treat the underlying cause. So all this along with the weight loss, diet, exercise will help in reverting back this disease. So NAFLD is common and silent, but it is not benign. So one has to take care of this disease. So basically lifestyle changes, they are the most effective treatment of MASLD. So thank you all so much for listening to this lecture patiently. I hope this presentation has given you a clear understanding of the metabolic dysfunction associated steatotic liver disease and all the new nomenclature, the pathogenesis and the morphology. Now we have seen that MASLD is a result of metabolic dysfunction. So we must remember to manage and prevent this disease is to identify and correct the underlying risk factors. So we have to treat the underlying diseases, and then we have to follow a healthy lifestyle. So if you found this video useful, please don't forget to subscribe my channel for more content and give it a like. And thank you for all your support. I will continue to make educational videos like this. Feel free to leave any question in the comment section below. Thank you so much. Never stop learning.